Transforming care through genomic medicine, personalized therapeutics, health services and outcomes research, and innovations in healthcare delivery. We're Children's Mercy Kansas City, presenting our audio interview series, Transformational Pediatrics, with host Dr. Michael Smith.
Today's topic is bone marrow transplant for the treatment of rare diseases. My guest is Dr. Rakesh Goyal. He's the section chief of bone marrow transplantation and professor of pediatrics at the University of Missouri, Kansas City School of Medicine. Dr. Goyal, welcome to the show.
Thank you, Dr. Mike. It's a pleasure to be on your show.
So tell us a little bit. I know that you're new to the Children's Mercy Bone Marrow Transplant Program. What are you, as the section chief, what are your goals for the near and far future for the program at Children's Mercy?
I am tremendously excited to be part of Children's Mercy Institution. I consider this as a family, and I had worked in this field for quite a while. In fact, in my prior institution, I worked on a number of new areas that are highly promising to cure children with these rare diseases with transplantation. And one of the reasons that I came here was that Children's Mercy, in terms of its vision, its capability, and its research platform, offers tremendous opportunity for me to build on my expertise and take this program forward.
Well, let's talk a little bit about transplantation, specifically bone marrow transplantation. How has the procedure, in your opinion, improved over the last few years?
Yes, I think So the main excitement in the field is that transplant is no longer indicated just for children or young adults who have cancer or leukemia, the former diseases which otherwise could be life-threatening or life-taking. But there are these new diseases and some old diseases which themselves are not like cancer or leukemia, but have grave implications for quality of life of patients and sometimes do shorten the lifespan of these patients. So the community and researchers such as myself have applied transplantation as a way to fix or cure these patients from these diseases, and the list just keeps expanding. So what has made that possible is a shift in the mindset of the transplant doctors and researchers, that we don't need to treat these patients as if they have leukemia, because we were giving them a ton of chemotherapy, sometimes a lot of radiation to make transplant work. Now what we have realized is that if the patient doesn't have leukemia, they have a missing gene product or they have a missing factor that makes them not feel well or be terribly unhealthy, like a weakness in immune system, then we can do a more of a precision transplant. And there we no longer use one-size-fits-all approach. We actually customize what a patient is going to get for transplant recipe. That way the patient sees less toxicity, there are less long-term side effects, and we are trying to preserve quality of life, including for a child, their growth, their development, and hopefully ability to have children themselves later on to start a family.
How exciting, right? Because now, and so what you just said about the list just keeps growing on the things that you can treat and even cure through transplantation is just going to continue to grow. Because you've really opened up the window, haven't you, with what you're doing now to really make an impact on diseases that we really didn't have many options for in the past. Is that right?
That is true. So there are several examples. One large example is the community of children who are affected by sickle cell disease, in which the red blood cells that make hemoglobin, which carries oxygen, and that is the engine for life, is defective, and that makes them terribly sick with a variety of organ system issues, pain, poor quality of life, sometimes even infarcts and strokes as a child. Then there is thalassemia, in which the patient is transfusion dependent for the rest of their life and then eventually may lose their life to iron overload. And then the other very exciting field is babies who are born with weak immune system, or what's called bubble boy syndrome, wherein their immune system is so weak that if somebody has a cold, that cold could prove lethal for them. And then states are starting to now do newborn screening. So that is another big development, meaning on that filter paper spot from newborn heel stick, now the list of diseases that can be diagnosed at birth before the child has even symptoms keeps growing. And then some of them are really transplantable. So the one big category, even though it's rare, but highly curable, is that category of immune deficiency, also called SCID. And then third large category is patients who have these terrible diseases they are born with called inherited metabolic diseases. And these include Hurler syndrome, which can be eminently cured with transplant, and then some diseases for which transplant should be considered as a research modality of treatment but highly promising. And those include diseases such as Krabbe's disease, some forms of metachromatic leukodystrophy, and I can go on and on.
Right, right. Yeah, so what about the process or the procedure itself? When, it wasn't that long ago, Dr. Goyal, that when you heard the word transplant, whether it was bone marrow, stems, or whatever, we all thought of allogeneic transplant, right? Where there's a donor, it's usually a sibling. There was always that the rejection that we had to deal with. So where do we stand with the types of transplants? Are we moving away from allogeneic? Are we looking more at the stem cell of the patient? I mean, where do you see that going? The actual procedure.
Great question, Dr. Mike. In fact, we still use or like to use a donor for majority of these types of transplant, because if you use their own cells, you can't fix the defect that they have that a lot of times they're born with. However, the choice of donor, that menu has expanded tremendously. So oftentimes we had to and continue to find a donor outside the family, given the American family size and structure. And therein come challenges for patients who may be from an ethnic minority, or they may have a family background that is relatively uncommon or maybe mixed. Then we always struggle how to find a good or perfect match. Now, there are two major developments in that field, and we actually are actively participating in both. One of them is umbilical cord bloods. So these are not the stem cells as we think of stem cells as in fetus. These are blood and marrow stem cells, and they are incredibly powerful. They are turbocharged, and they work extremely well. So the field of doing transplant from cord blood has taken off in a very good way, especially for children. And then last but not least, haplo-identical transplants, meaning if you can't find a brother or a sister, or you can't find a suitable cord blood, then what do? Well, there is always a parent oftentimes too. So now we actually have tweaked and developed. There are recent pioneers who have actually perfected that technique. And I have no hesitation in actually calling up a mom or dad or a brother who is not even matched and use them. So we actually are moving to a field where anybody who needs a transplant, especially a child, would have a donor. So that is extremely exciting.
Wow, yes, that's really exciting. It must, Dr. Goyal, it must be very exciting for you personally to be at the forefront of such an exciting field with so much potential. Just for the last question, give us your own personal opinion about where you really see transplantation going into the future. I know you hit on a lot of things already, but just kind of summarize for us what excites you about the technology.
I think the main, even in my practice time over the last nearly 2 decades, it's so gratifying to see that children don't get as sick when they're going through transplantation. That is not always the case. If you have a child with leukemia who already has had a lot of treatment, that's different. But a majority of time, so our focus right now is to make transplant as safe, as non-toxic, and preserve the quality of life for later on, so that these transplant survivors, having beaten their underlying terrible disease, can have normal life experiences and can be gainfully employed and go to college and do all the good things. So I see the field of transplantation in terms of continuing to improve and fine-tune. And it's I believe it's going to be personalized. And with the discovery in genomic medicine and how we know everybody's metabolism and body works, we'll be able to actually come up with a recipe, no longer one size fits all, no longer one big bang type of an approach.
Yeah. Very exciting stuff. And Dr. Goyal, I want to thank you for coming on the show today, and thank you for all the work that you are doing. It really is exciting. to see what Children's Mercy is doing and how exciting it is for you to now take over the reins there. Good luck to you at Children's Mercy. You're listening to Transformational Pediatrics of Children's Mercy, Kansas City. For more information, you go to childrensmercy.org. That's childrensmercy.org. I'm Dr. Mike Smith. Thanks for listening.